so more about back labor. Hands and knees position is really good because that occiput, the back of the baby's head is pressing into mom's back. That's why we call it back labor, all right? And if you felt it, you'd call it that too, along with a couple other adjectives. So hands and knees helps gravity to kind of pull away from the pressing on the back.
She doesn't look pregnant.
No, I don't like this picture whatsoever. Clearly it's from the 1970s, yeah. Anyway, sacral counter pressure. That's, you could do that with a tennis ball, you can do it with the heel of your hand, that's between hands and knees if you can do that, and the sacral counter pressure. Those are the two most important non-pharmacological pain relief methods for back labor. Issue with back labor, the issue with occiput posterior. So when the baby's occiput is facing mom's back, it may not line up well. The widest part of the baby's head might not line up with the widest part of mom's pelvis. So all of that pain might be for naught because the baby won't fit out of your pelvis. Anyways, second stage of labor comes, we're starting to push. There's education that a nurse does with everyone involved, how to push, when to push, how long to push. Don't push with your face. No, don't push your eyes out. Push down here. Can you feel this? Push here. All sorts of things that we do to get them to try to push. For some, it's instinct. They feel their body pushing and they push. And for others, not at all. So we just have to do our jobs and make sure they can push as best as possible. Lots of monitoring of both baby and mom, vital signs and fetal heart rate, and contractions. Obviously, we have to watch contractions and push only during contractions. We need to give the baby a break in between. Everyone needs a break. Not the more you push, the quicker it'll happen. We need everyone to have a break and then come back to it during a contraction, all right? Baby gets born, and now we're dealing with lacerations. Like if there was any tearing of the soft tissue, we break it down into degrees. First degree, second degree, third degree, and fourth degree. First degree is just through the skin, a little bit into the muscle. Second degree goes through the muscle. Third degree goes to the anal sphincter. Fourth degree goes through the anal sphincter. So makes two holes one.
It's a fissure. It turns into a fissure.
It does indeed, quite a large one. Oftentimes, rectal, oh yeah, it leads to some pretty chronic problems later on if it's not repaired properly. Even if it is repaired properly, there might be so much damage, nerve damage, muscle damage, that sort of thing. Oftentimes, with extensive lacerations, fourth degree lacerations, the obstetrician will actually bring in colorectal surgery to assist in the repair. Yeah. The second stage of labor requires quite a bit of nursing. It's my favorite. Transition and the second stage really are my favorite because it's what I'm doing, what I'm trained to do then, right? I'm in there. I'm a cheerleader. I'm a teacher. I'm a detective. I'm watching for clues. I'm doing everything. This is when I'm at my best, is when I got something to do and that I obviously love. And pretty soon I'm going to meet my second patient. So I'm pretty pumped about it all, really. All right. In the meantime, as we're doing all of this, we got to make sure we're ready for our second patient. Oh, it could be hours and hours, and all of a sudden we're like, we don't have oxygen, or we don't have the warmer set up the way we want it. So along the way, somebody either needs to help you, or you need to be able to make sure you have all the emergency equipment we need to welcome that baby and available in case we need it. Here in America, our typical birth position is kind of semi-Fowler's, lithotomy kind of position. It's not the ideal. In fact, squatting is the ideal position, I think. Back in the day, they used to be on their side with their leg up. I don't know. That's where technology kind of gets in the way, because we're too busy monitoring the patient, and that's the best way to monitor the patient. Well, it might not be the best way to get a baby out, but squatting uses gravity, and it opens the pelvic inlet, the most ideal. So there's like modified squatting. We have squatting bars that we have so that they can squat like on the mattress, and so that we could at least have access to what's going on, which, you know, if you're in a hospital, we really should have access to what's happening and try to ensure a safe delivery. So there's different things that we can do to help nature along. I never forget it. This woman insisted on delivering on her hands and knees. She wanted to be on her hands and knees, which means everything's upside down, right, for the practitioner, because they're used to having, yeah. So this doctor, in fact, the same doctor I talked about before, was like, ooh. He wanted to do his best for the patient, but he kind of lost, like, how he was supposed to. He's like, ooh, I'm never going to, ooh. So I tried to turn out okay. And once he figured out, okay, this is where I'm doing, no, he did all right, but it was cute. But like I said, he wanted the best for his patient, but he was just a little confused as to how to do it. Mm-hmm. These are some different positions. This is the squatting bar I talked about. So we still have access to the action in there. All the different.
She's in a sundress.
Yeah, isn't that pretty?
White sundress.
She's just like in a dance hall.
I know. Yeah. So like a dirty dancing scene.
Yes, indeed. Nobody puts baby in the corner.
That's right.
Right? Corner over there.
She's got
All right.
shorts on too, doesn't she?
Clearly, that's just demonstrating the position. Okay. So, I know. This is a great picture here. So, as the baby is descending into the pelvis, we have different things that we're feeling. Some hopefully aren't feeling anything if they're epiduralized nicely. But no matter what, it gets to a certain point where universally, at this point, this is when what we call crowning. The crown of the baby is making its exit, all right? It's right back here that's coming out first, all right? This point is called crowning, and we also call this the ring of fire. You know Johnny Cash? Go down, 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 the ring of fire, the ring of fire. Now you'll never hear that song again without thinking of this image right here. No matter what culture, no matter what medication, no matter what anything, a woman gets to this point and she complains about the burning. Because the perineum is as stretched can be, and it burns. It burns, burns, burns. Sorry, but yeah. How about you? Did you feel it? Yeah. Epidural or not, it burns. So it is officially called the Ring of Fire. Episiotomy. We have the midline episiotomy, which is straight down, and a medial lateral episiotomy. It's all doctor's choice, really, which is slightly off to one side or the other. Most often I see it on the right, but the issue with that is some doctors do it, some doctors don't do it. An episiotomy can shorten the second stage of labor to get the baby out quicker. Say the baby's tanking on us and we really want that baby out, a doctor might cut an episiotomy so that it comes out quicker. I get that. Some doctors sincerely believe that a clean cut is easier to repair and heal than a jagged laceration.
Or a fissure.
Mm-hmm. Some will say that if left to tear on its own, it will be less superficial. More superficial. Sorry, that did you see me? I had to think about English a little bit on that. Less deep. It'd be more superficial, not as extensive into the muscle. Because the second, an episiotomy is equivalent to a second-degree laceration, so it cuts into the muscle. You have as many opinions for as against, and I just present the facts. Whatever.
Can the woman feel when they cut?
Yes.
Oh,
Some can, some are feeling the ring of fire and they don't feel the cut that comes along with it. Yeah. Yeah.
I haven't talked to many who said they didn't feel it.
How do you have more kids after that?
Forget. We totally forget. It's like
It's worth it, because that's the last, well, I don't know, I've never felt it. So. This is a little bit more about, as I mentioned, through the skin and subcutaneous tissue to the muscle. Second degree is through the muscle. Third degree, through, but not, through the sphincter muscle. And the fourth degree, booms, right through the rectal wall. So
Do we need to
through the
memorize
sphincter.
these?
Do what?
Do we need to memorize these as far as the degrees of laceration?
I don't recall.
Okay.
Yes.
I think it's probably, no, I really don't recall if I have any specific questions on any quizzes or finals. I think it's a pretty good piece of information to know, but I'm kind of kooky that way. There's a picture for you. Fourth degree, yeah. All right, then we're in the third stage. All right, the third stage of labor, if you recall from way back, is from the delivery of the baby to the delivery of the placenta. So baby's up on mom's chest. Mom care less about anything else, right? Generally. She's got her baby. In the meantime, provided baby is doing well, we can do everything we need to do right on mom's chest. We can dry the baby off, right? Remove the wet blankets, put on a hat, get in there, listen to the heartbeat, assess respirations, color, muscle tone, and reflex irritability right there on mom's chest. And mom and dad get to meet their kid. Third stage of labor is about the delivery of the placenta, the separation of the placenta from the uterine wall, and the delivery thereafter. Can take from 5 to 30 minutes. Where is a doctor who will wait a whole 30 minutes? They start tugging after a couple minutes. Like, I'm gonna get this. I mean, nothing against it, but like, well, we gotta wait. 30 minutes is a long time to sit there waiting. So they might think, that giving it a little tug might move it along. Anyways, it can take all the way up to 30 minutes. If the placenta is not detaching and it's been more than 30 minutes, then they have to intervene. There's an abnormal attachment where that requires either a D&C, anesthesia with a manual extraction, or it could have gone deeper into the uterus. And we'll talk about that at another time. But that's why we have to give it 30 minutes. That's what we have to wait 30 minutes before we become concerned about.
I didn't even know this is something you had to do. Like, I was like, what do you, I thought something was wrong when she started pushing on my stomach. And she was like, yeah, we're not done. I'm like, no, she's here. Of course
Right.
she's done. Like, this is it.
Right. So there is actually, so we have the baby, maybe, these days, generally we have at least 2 nurses in the room. One responsible for the baby, one the circulator doing everything else in the, like assisting the practitioner, monitoring, keeping tabs on things. A placenta will tell us when it's ready to come out. There's usually like a gush of dark red blood, and the umbilical cord, if you watch it, will actually lengthen, will actually start coming out. And that means the placenta is beginning to separate, and the practitioner will guide it out.
It makes
Right.
this noise. And it drops in the thing.
Good times. Then, usually there's a pretty good swift gush of blood following that. That's when the nurse will get in there, sometimes the doctor, and start mashing on your belly, massaging the uterus to kind of get it to start the cramp. They say there is a little bit of pain. It's a contraction, and from the separation as well. But generally, the moms are kind of distracted because their kid is like right here. They'd be like, ooh, ooh. Like, ooh, what's that? Wait a minute, what are you doing? And yeah, we're continuing to do our job there because we're just in the 3rd or 4th stages. But it's almost over. Delivery of the placenta, then we worry about postpartum hemorrhage. Delivery of placenta moves us into the 4th stage of labor, which is postpartum, first couple of hours. Of course, we're doing all this business. Oh, remember, ID. We got to ID that baby. Mm-hmm. So if you were watching her uterus, you might even see it rise a little bit with the contraction. Lengthening of umbilical cord, sudden gush of blood. Those are the 2 signs that usually are indicative of a placenta on its way. Here's your pictures. This is when we'd start mashing on a baby, on a belly. This is when we're gonna open up and the IV fluids with that Pitocin in it and give a big old dose of Pitocin. Sometimes Pitocin we need a little bit more than Pitocin. Like if mom is going to do some heavy bleeding, this is the time it's gonna be done. All right. We might need to give mom some Methergin. Methergin, I think I talked about that way back in the beginning. Methergin is a great drug, but we have to watch. We can't give it with high blood pressure. I told you about the lady who I could hear the blood rushing out of her. Mm-hmm. This was during the, 3rd stage of labor had just finished, and we were on to the 4th stage where she was giving me a run for my money. So yeah, we're gonna have to do that. And then the 4th stage is literally monitoring mom and baby, particularly mom, to be honest with you. Vital signs every 15 minutes for an hour. At the meantime, we're checking her fundus, we're checking her bleeding, we're checking comfort level, we're checking bonding, we're doing education. It's a great time. We're cleaning up. I've delivered a baby and mopped the floor in the same room. So we're literally cleaning up. But you do what you got to do to create the family, right? The grossest, most beautiful thing I've ever seen. Amen.